All right. Hi, everyone. Good evening. Erev Tov. It's great to see everyone on tonight. Phil asked me to kind of kick things off. As you know, I'm Dan Cohn, or if you don't know me, I know we have a few guests on tonight. I'm the president of Congregation Anshai Torah. And I want to say, first of all, I'm really appreciative of all of what Hazak has done. I'm really impressed with the programming that you guys have done, even throughout COVID. You've been very, very active with incredible number of interesting and engaging programs like this one. And we really always appreciate it when you open it up to the rest of the community as well, like you're doing tonight. So that's terrific. All the work that you guys do has been wonderful for us. Of course, Dr. Jeffrey Kahn is here with us tonight, and you probably know his face already because he has spoken to us on a number of occasions, including one of the earlier Hazak events. And we are really indebted to him for all of what he's done for us, during COVID, especially with his willingness to come and speak and teach us and guide us. He's part of our COVID-19 task force. In fact, I just got off a call with him not more than maybe an hour ago. And we were having one of our weekly sessions. So we're really appreciative to all the time that he gives and how he helps us out. So I don't want to say too much more here. I'm going to turn it off to our speakers. Dr. Kahn and Dr. Mark Meiches will be our moderator for tonight. Mark, as you may know, as Michelle Meiches' other half, or like me, you may know him through other channels like Men's Club. And we're really happy to have him kick things off tonight. So Mark, I'm going to turn it over to you and let you introduce Jeff.
Thanks, Dan. And again, thank you to Hazak, and especially thank you to Phil Bayless for all the work he's done putting this program together. I'm going to go over a few little bits of housekeeping, and then we'll get right to Jeff. The first one is a disclaimer like we did last time. The COVID situation is very complex, especially for older populations. So whatever you hear today is a generalization, but if you have any concerns or questions about whether it's appropriate for you to get the vaccine, certainly contact your own personal physician and check with them. Make sure they say it's okay. I know at this time they're very attuned to people contacting them and asking that question. So feel free to reach out to them. I'm sure they'll get back to you if they have any concerns. Regarding questioning, thank you all for sending all your questions in advance. I think last time we did this, it worked very well, and we're going to use the same format. If you have any questions, please send them on the chat function on the Zoom page to me, and I will sort through them, make sure that we've got them included or add them, and feed them to Jeff as time permits to make sure we can get all your questions addressed. Very briefly, some of the things I know we're going to cover tonight to give you an idea is how do I get the vaccine? Literally, where do I go? How do I sign up? Will the vaccine be effective for me, or how do I know? What are the risks of this vaccine? And some miscellaneous other things about testing. And one subject I want to cover real quickly to kind of give you a warning about is resuming a normal life. If you can believe it or not, the last time Jeff spoke was 3 months ago on Zoom. And at that time, he told us everything we needed to know about COVID. But the one thing we basically told you we can't answer any questions about is the vaccine, because we didn't have any answers. Here we are 3 months later. Many of you have probably received the vaccine, or at least a few of you have, and you will shortly. So we've made amazing progress. And Jeff's going to tell you everything he can about the vaccine. But one thing you're going to ask about, and I'm afraid we don't have answers, is when do we go back to normal? That's something that only time will tell. Jeff will give you some insight into that, but it's not a clear-cut answer as to a week after you get your vaccine. So you can ask some questions if you have them, but don't expect a whole lot of answers as to that. When can I do this? When can I do that? Because we just don't know. That's something that our government or the doctors in charge will ultimately let us know as that develops. It is my pleasure to once again introduce Jeff Kahn, who's the Chief of Pediatric Infectious Disease at UT Southwestern. I don't know if any of you yesterday morning had the experience I did, but I was laying in bed very early and I could swear I was dreaming that I heard Jeff's voice. And I realized I wasn't dreaming, but I was listening to KERA, and Jeff was there being interviewed by Sam Baker, talking about pediatric diseases and how they've been affected by COVID. So Jeff is not only serving our community, but really the whole Dallas-Fort Worth community. And on the same note, I do want to alert everybody that 1 month from now, on February 5th, Anshai Torah Sisterhood is hosting their annual Sisterhood Shabbat, and they are honoring Jeff and his lovely and talented and amazing wife, Marcy, with their 2021 Torah Fund as their honorees. So please, we've got 200 people signed up tonight. It would be lovely for 200 people to show up on Zoom Friday night to really show our appreciation to Jeff and certainly to Marcy for all they have done and continue to do for our community, both at Anshai Torah and throughout the area. So onward to Jeff. Jeff, I've heard that there's a vaccine out there. What can you tell me?
Well, first of all, thank you, Mark and Dan and Phil, for the opportunity to speak and the invitation from Hazak. It's really wonderful to have an opportunity to speak to you once again. I do have a short presentation that I think will be helpful in answering some of the questions. So if you don't mind, I'm going to share my screen. Dan, can you let me share my screen? Let's see.
Yeah, I think you should be able to, but if not, let me see. Hang on a second. Oh, sorry. Let me set it up so you can share, Jeff. Sorry about that. Hang on one sec. Didn't realize you were going to share. Here we go. Let's do it that way. All right. So now, now you should be okay.
Okay, good. All right. I'm going to share that. And I hope everybody can see my screen.
Yes, I can.
Okay. So let me give you an update about the pandemic and where we stand with the vaccine, the 2 vaccines that are now currently available in the United States. So a few things about where we stand with the epidemiology. Some of you may be familiar with the Johns Hopkins University COVID dashboard. It's showing you where the activity is in the United States. You can see here that Dallas County is now in the top 7 counties as far as COVID cases are concerned. So we just passed 200,000 cases in Dallas County. Here is a graph looking at COVID in the United States going from January 22nd, the first diagnosed case in the United States of COVID. COVID probably was circulating beforehand, but this was the first date that it was diagnosed here, going all the way over to January 3rd. And hard to believe, we are almost at a year of dealing with this virus in the United States. So far in the United States, almost 21 million cases of COVID. And shockingly, a third of those cases, 7 million cases, have actually occurred in the last 31 days. And you can see the slope of this curve is quite steep. And the basic projections, which I'll get into in a few minutes, looks like this is going to continue. And we reached a very grim milestone recently that 1 out of every 1,000 Americans have died of COVID-19. Right now, we're north of 350,000 fatalities in this country due to this virus. Here's some more local data. This is looking at Dallas County Department of Health data. And again, everybody will remember we had a big peak of COVID activity and hospitalizations in the summer, late June, early July. That sort of died down, and now we're seeing our second wave. And as I've mentioned, perhaps in the previous talks I've given here, if you look at pandemics, particularly these respiratory viruses, the second wave and the third wave always tend to be worse than the first wave, and I think we're seeing that here. Whoops. Dallas County also puts out with these sort of heat maps to show you where the activity is the greatest, the dark red here. This hasn't been updated in a couple of weeks, but I imagine Dallas County will be updating that data. A shout out to my colleagues at UT Southwestern and their modeling system. They put out this report. It's publicly available every week, and you could see here that the hospitals, and this was a report that was updated just December 30th, so just a handful of days ago. Hospitalizations for COVID-19 are an all-time high in North Texas. Dallas County is still on an upward trajectory with a projected 10% further increase in hospitalizations by next week. Tarrant County is actually doing much worse. They're expecting 35% increase in hospitalization. So it looks like Dallas is really mirroring the United States as far as the pandemic is concerned. Here's a graph looking at the lab confirmed COVID occupied beds going from August to January. The red bars are ICU beds. The blue bars are non-ICU beds. This is the curve here, and these blue lines. This blue line here represents what the model is predicting, and you see it's been very accurate up to this point. These are for all beds, and this is for ICU beds. And again, this is in Tarrant County. The slope here is much steeper, so it looks like the projections are that Tarrant County is going to be hit a lot worse in the next couple of weeks, at least compared to Dallas County. Dallas County also puts out data as far as who's getting infected as far as by age group. So this again, looking at the weeks, this starting in March, going all the way to the last week of December, and in the age groups. And you can see that in the latest peak, just about every age group is being is involved in the pandemic. And you can see that the numbers have gotten so high that Dallas County had to recalibrate their scales to deal with this. And this is actually looking at Dallas County by city, and you can see just about every city there's a lot of COVID, maybe with the exception of Richardson here. So now I want to shift and talk about the vaccines here. What we have on the right-hand side is a cartoon of a COVID virus, the SARS-CoV-2 virus. And this actually on the left-hand side is an electron micrograph, actually the first published picture of the COVID virus. And you get a sense that there's sort of a crown around this viral particle, another one here. And that is the corona, and that's where the virus got its name. But the most interesting thing, at least where vaccines are concerned, are these knobby little particles here, which are the spike protein. You'll hear me refer to the spike protein. And here are the vaccines that are at least being considered here in the United States. There's the Pfizer mRNA vaccine, the Moderna mRNA vaccine. I'll go into a lot more detail about these. And several others here. Johnson & Johnson has a vaccine. Astrazeneca, that vaccine was recently approved in some other countries. And Novavax. These are different platforms. But the two vaccines I'm going to be talking about today are what's called mRNA vaccines. And you can see that they're recently approved. They got emergency use authorization by the FDA in December. And you can see they're highly effective. And this is the age group for individuals who are eligible to receive the vaccination. So I was asked earlier, what exactly is mRNA? And the M actually stands for messenger RNA. And I sort of struggle with how long to try to put this out there. But essentially, mRNA is the first step in the translation of our genes, which are encoded in our genome. So, and I apologize beforehand for the metaphor here, but sort of think about it like this. So here's the Torah, the scriptures, and so one can say that this is sort of the genome or the genes of the Jewish people. And the words are written here in letters, much like our own genome. We have 3 billion letters in our own genome. And the words are written here, and it's essentially an instruction manual. And the words on the parchment really mean nothing until somebody actually does something with them. So we need a messenger. And of course, in Anshai Torah, we have our messengers here. These are our 2 rabbis who read the Torah, who translate the Torah, who interpret the Torah, who give us their guidance based on what's written in the Torah. And of course, that results in actions and activities and so on and so forth at Anshai Torah. So these are the messengers, if you will. There are times where other messages come into our synagogue. So for example, in April, the state of Texas put restrictions on religious gatherings because of COVID, and of course we had to close. But this is an example of a message coming in. It doesn't affect the text of the Torah at all, but it's another message that leads to some type of activity. And hopefully we'll put this in perspective with this slide. So here's a cartoon of exactly what these mRNA vaccines actually do. And they're actually made up of thousands, hundreds of thousands of these microscopic lipid particles. And they have a piece of mRNA, a messenger RNA, but this messenger RNA actually encodes one of the virus proteins called the spike protein, which I pointed out earlier. And the mRNA gets into the cell and it's translated, and actually our cells start to produce the spike protein of the coronavirus, and this allows our immune system to see the virus, to see the spike protein, develop an immune response to the spike protein without being exposed to the virus itself. So this is not necessarily a new technology. The first clinical trials of using mRNA were actually in 2008. It was the first clinical trial. It didn't deal with COVID, of course, but it dealt with something else. And we know that there are many advantages to this. They're non-infectious. They have a very good safety profile. I will get to that in a moment. They have a very simple structure. They are not gene therapy. I think it's very important to know that it does not alter our DNA. And perhaps we could talk a little bit more about that later, but mRNA does not affect our DNA. And it really relies on the genetic code of the pathogen. And what's really, really advantageous about this is that they can easily modify it. In other words, you could change the wording here, if you will, on the mRNA molecule to change it if the spike protein were to change, for example. We'll talk about that briefly. So here's the first example, or the first publication. This is the Pfizer-BioNTech vaccine. And again, it's an mRNA in a lipid particle. It goes into the cell, you get the spike protein. Here's the data. So they actually did this clinical trial where they immunized about 22,000 people got the vaccine, and about 22,000 people got placebo. And you can see the number of symptomatic cases here. In the placebo group, 162. In the vaccine group, 8. So this is about 95% of this, and that's how they come up with the vaccine efficacy. For severe COVID, interestingly enough, there was 9 cases of severe COVID in the placebo group, only 1 in the vaccine group. And here's a graph that again represents the 2 groups, and along this axis is the cumulative incidence. And you can see the people who got the vaccine group, the people who got the placebo continue to get COVID, while the people who got the vaccine really didn't get much COVID at all. And if you look very carefully at this, and again, this is the Pfizer vaccine, it's dosed on day 1 and day 21, that these 2 graphs actually start separating before day 21, suggesting that 1 dose of the vaccine will actually work. And if you look deeply at the data, you can see here that after dose 1, but before dose 2, the vaccine has efficacy of about 52%. Now, I'm certainly not suggesting anybody get 1 vaccine dose, but you do get a benefit of 1 vaccine. And this really speaks strongly to the fact that you have to get 2 doses. Very busy slide here. These are the safety profiles. Again, most of them are pretty mild symptoms, local events, swelling, pain, and very few systemic features. Now, this is the Moderna. This is the Moderna vaccine. Again, this was published just a few days ago. And again, very similar graph here. 2 groups, they got a placebo group and a vaccine group. Here, this graph, they got a dose on day 0, a dose on day 28, and then they start counting 14 days later. So this is right here. And you can see the placebo group gets COVID, and the vaccine group does not get COVID. Another way of looking at this graph is instead of starting the clock here, or at least the measurements here, can we start the measurements back here? And this is something called a modified intent to treat analysis. And you can see even before the 2nd dose, these graphs are starting to come apart, and it really strongly suggests that 1 dose of the vaccine does provide some protection. And you can see here that 35 people who got placebo 1 dose got COVID, only 2 who got the vaccine got COVID. So it looks like, based on this, it's very, very effective. And again, the Moderna vaccine trial was actually quite good because they looked at older individuals, they looked at individuals who had high risk factors, and so on and so forth. And the vaccine efficacy was really quite strong across the board. Some of the error bars here are kind of large simply because the numbers were small. But again, we're looking 80, 90% efficacy of this vaccine. Very, very promising. And again, this is looking at side effects. I won't go through a lot of the details, but the gray bars are mostly mild side effects. So many of you are probably thinking, well, where can I get my dose? I often wonder that as well. I urge you go to the Texas State Department of Health Services. And this was a release that was out yesterday, and it talks about where the vaccine is being distributed to. And there are links where you can see where you can get your vaccine. And I took a screenshot, and you can see that there are a number of places in Plano to get it. But of course, each of these places only has 100 doses. So it's quite challenging, but I would keep an eye on the Texas State Department of Health website for information in that regard. So let me talk a little bit about the post-emergency use authorization safety concerns. And there have been things in the media about severe allergic reactions to the vaccine. And this is Actually, not necessarily surprising. Even in the vaccine trial, there were a few people who experienced allergic reactions. But it seems to be a very rare event. And the CDC has actually put out some recommendations here. So contraindications, these are instances where you should not get the vaccine. If you have a severe allergic reaction after a previous dose of the vaccine or any of its components. So if you have a reaction after the first dose, you shouldn't get the second dose. An immediate allergic reaction to any severity to a previous dose of an mRNA vaccine or any of its components. And again, when you get your vaccine, the people who are administering are going to ask you these questions. And of course, a severe allergic reaction to, again, some of the ingredients in the vaccine. So what about precautions? The CDC considers a history of immediate allergic reaction to any other vaccine or injectable therapy, either it's intramuscular, intravenous, or subcutaneous vaccines or therapy, not related to the component of the vaccine, as a precaution, but not a contraindication to get either one of these vaccines. And if you happen to have an allergic reaction against food or pets or environmental allergies or allergies to oral medications, that's neither a precaution or a contraindication. You can go ahead and get the vaccine. So I want to finish by talking about these new variants that we've been hearing about in the news, and there are two that are causing a lot of concern in the medical and scientific community. And the first is the United Kingdom variant of concern. This is called the B117 lineage. It's popped up now in many countries. As you probably heard in the news, there have been several states, including Colorado, Florida, and California, where this variant has been identified. This seems to be a lot more contagious than the viruses that were circulating earlier, the strains of the virus circulating earlier. There's another variant in South Africa that has not been detected, at least in North America yet, I believe. But I want to talk about these variants, at least in my mind. So here are some of the media alerts about this new variant, and you know that the United Kingdom has now shut down basically their country because of this variant. And I think, let's see. And so here's the cartoon of where this is a variant. Here's the virus again. You can see the spike protein. It's accumulated a number of mutations, and not to get too much into the weeds here, but it seems that these mutations are allowing the virus to spread more rapidly in the community. And here's the data that supports that. You can see that the cases in the UK were dropping till about December 1st. And then they really started to climb. Whereas by nearby European countries, there wasn't that big spike. And it's thought that it's the variant that's behind this, also the variant that's circulating now in South Africa. So again, just to summarize everything, I know I've gone through this rather quickly. We know that COVID-19's cases continue to rise locally, regionally, and nationally. There are two mRNA vaccines that received emergency use authorizations, the Pfizer-BioNTech and Mrna Vaccine. There's a very favorable safety profile, and they seem to be very, very effective. We have these new variants, and they appear to be spreading more rapidly than the original strains. There's implications for the vaccine. The question is whether immunization with these either of these vaccines will provide protection against these new lineages. The thought is they should, but now both Pfizer and Moderna are doing experiments to determine how effective these vaccines are for protection against these new variants, both from the UK and South Africa. I should point out, lastly, that these viruses do this. Variants are to be expected. And every virus that we look at, particularly these viruses that are based on mRNA or RNA, I should say, mutate very easily. And one example of that is the fact that we have to get a flu vaccine every year because the virus mutates, and the vaccine given last year may not protect against the virus this year. So this is going to have profound implications for the control of the pandemic. And I think this is going to lead to some questions when we go back to normal. Well, it really depends on how good these vaccines are against protecting against these other strains. So with that, I'm going to stop sharing. And I went through that rather quickly, and I'll be happy to answer some questions. I think Mark is going to be the master of ceremonies here as far as the question and answer period.
Thank you, Jeff. We've got a whole lot of questions, so I'm going to kind of keep them in categories. And let's start with the basic question a lot of people have is, how do I get the vaccine? You mentioned the Texas State Department of Health site, and I know the Dallas Morning News also has a reference and a link. To clarify, most of our listeners or our Zoom goers are over 65, so they're going to be in phase 1B, which is the next phase. So how will people know it's their time? And by the same link, we've got some younger people who are saying, I'm sort of a normal person who's probably in the last group. Again, how will I know when it's my time to start signing up?
So what we do know is that the first shipments of vaccine went to hospitals. They didn't go to universities. They didn't go to CVS or Walgreens. They went to hospitals. So if you have a physician who's affiliated with a hospital, I would contact that physician because at least the experience we have at UT Southwestern, we're starting to immunize our patients. So again, if you happen to have a physician associated with a hospital, contact that physician. Otherwise, it does get kind of murky. The rollout of this vaccine has been clunky at best. So you have to keep an eye on these websites. And Dallas Morning News and other local news authorities will be able to help with that. But it's a little chaotic right now, and we had that experience at the hospital where I received my vaccine. The shipments were delayed. We weren't sure what was going on, and we weren't sure the number of doses and so on and so forth. So it's going to be a challenge for the next several weeks to months once they get all this sorted out.
And I think you pointed out with these various facilities, I know one thing the press has really been pushing is you can't just show up. You have to call in advance, make an appointment, right. Make sure they've got enough for you. So wherever you choose to go or your doctor says, be sure you call them in advance or you'll be disappointed. Some people are asking, does it matter which of the vaccines I get, the Pfizer or the Moderna, or will I have a choice, or does it matter?
Well, most likely depending on where you go, the pharmacy, the hospital, the facility will probably only have one of the two vaccines. They're essentially equivalent, but they're not interchangeable, and I'll get to that in a moment. So if either of the two are very, very highly effective, of course we don't know the durability of the immunity. We're going to learn that because we're just starting to immunize large numbers of people. But if you can get on a list or go to a facility to get one of the mRNA vaccines, go ahead and get one of the mRNA vaccines. They're essentially the same.
And go ahead and say what you're going to about not intermixing. A lot of people are saying, can I get one here and then the other one? So go ahead and cover that if you would.
Right. So the recommendation is to get the same vaccine as your second dose. And the reason, of course, is that because we don't really know what happens if somebody gets a Pfizer vaccine first and a Moderna vaccine second, or vice versa. We don't know. It's likely that they'll, in that combination, they may provide as robust protection, but we simply do not know. The CDC has been a little vague on this, but now that we're just seeing the first wave of vaccines, this may become an issue as 21 or 28 days go by. But try to stick with the same vaccine that you got for the first dose as for the second dose.
We have a lot of questions about the effectiveness of the vaccine. We know that 94, 95% are effective, but ultimately, how does an individual know that they are effective? And along that line, should we be testing ourselves for immunity or only certain people? How do we know, how safe we really are?
Well, there's no testing that's recommended or required after your second dose. And there are a couple of reasons for this. One, it would be a logistical nightmare to get everybody to get a blood test. Two is that even though the blood test can measure antibody levels, we don't know what antibody level actually correlates to protection. So in a sense that if you got a blood test and it says that you have an antibody level of X, we don't know whether X is good enough or not good enough. But we do know, at least in the short term, that the vaccines are 95% effective, and they seem to be even more effective against protection against severe disease. So yes, you may be one of the unfortunate people who are in that 5% that aren't protected by the vaccine, but 95 is really, really good. I mean, that's putting it up there with the very best vaccines that we have. the measles vaccine, for example, is in the 90% range. And think about when the last time you saw a case of measles.
Regarding the variability of these newer strains, you said we don't know for sure. We think they're covered. Things like measles and chickenpox, we've gone 80 years, and basically the vaccines that were established are still good. On the other hand, flu vaccine changes every year. So can you give us some perspective on what the expectation is of this virus in that sort of spectrum of we'll never have to change it versus who knows, it may change next year?
Right. So we as you said, we don't know the durability of this vaccine. We don't know whether we're going to require booster shots every year like we do for flu. These variants are somewhat worrisome, of course. As I mentioned earlier, the real benefit of these mRNA vaccines is they're very easy to modify. And so we can easily cover the variants as they emerge. Of course, we'll sort of behind the ball a little bit, but so it may be that we may need booster doses every year. It may not be, because it could be that the standing vaccine now provides enough protection against the variants if you happen to be infected with one to still provide significant protection. We're gonna know the answer to that question, and we're probably will have some data pretty soon. So more to follow on that. I think it's very, very promising. And remember, we talk about this herd immunity thing. So once we get a lot of people vaccinated, and there have already been 20 million people who have been infected, that's really going to curtail the circulation of the virus. And at that point, the likelihood that you get infected will be even lower, even if you happen to be in that 5% who don't respond to the vaccine. So I think I'm very optimistic about the potential of these vaccines.
Several questions pertaining to the risk of the vaccine. If someone has allergies in general, none of those specific ones you mentioned, but still normally they might take antihistamines beforehand, that sort of thing, have shellfish allergies, which is a common allergy. Should people do anything differently with antihistamines, or should we just treat it as you either get it or you don't?
Yeah, right now the recommendations are just to go ahead and get vaccinated. Allergies to foods or even some oral medications, that is neither a precaution or a contraindication. Go ahead and get vaccinated. Again, these are very, very rare events. And when you think about how many doses have been given in the United States over the last couple of weeks, and they're just a small number of cases, so it's very, very unlikely. And of course, not that you want to have this reaction, but it's easily treated, this reaction. So you have to weigh the risks of perhaps reacting to the vaccine in a bad way versus the benefits of the vaccine. And I think for everybody on this call, undoubtedly, the benefits of the vaccine outweigh the risk, unless you've had an allergic reaction to some component of the vaccine. I imagine that nobody on this call has had that.
Regarding the risk profile of the two major vaccines, if someone does have an allergy issue, should they prefer one or the other, or are the risks, the allergic risks of one worse than the other, or are they also found to be about the same?
They're all about the same.
Okay. Talk a little bit about the Astrazeneca vaccine. People have heard about that, but the thing that I think a lot of people are struggling with is they talk about a 65% efficacy. And so how is that better in any way when we've got a 95?
Now, that's a great question. So I think one of the big driving forces behind the AstraZeneca vaccine is actually the cost. It's significantly less than the Pfizer vaccine and less than the Mrna vaccine. So for certain countries, this may become this is an economic issue. On the other hand, we don't know long term. Will the AstraZeneca vaccine actually have greater durability than the other two vaccines? But right now, based on the data that we have, and the fact that we're distributing mRNA vaccines, by all reason, you should be getting one of the two mRNA vaccines.
Okay, thank you. And I don't know if you'll have these answers, but there are a lot of questions now when people are getting vaccines. Can you get the illness? Should you get tested for COVID? What do we do in this interim when you are being tested? So the first question, I guess, is if I have been vaccinated, can I still get COVID during that, between the two?
In between, yes. So after the first dose, the vaccine's about 50% effective. After the second dose, much less. But the one thing we really don't know is whether you can get affected and have asymptomatic infection. In other words, after you get your 2 doses, you may encounter the virus, never know you're sick, never know you've actually had the virus, but you still can be spreading it. So that's why, even if you've been fully immunized, you should wear a mask. And in this case, in some part, you're protecting yourself because you may be part of that 5% who didn't benefit from the vaccine. But on the other hand, you're protecting everybody around you because you happen to be wearing a mask. So when we think about what's going on in the hospital right now, for individuals who have gotten 2 doses of vaccine, all the practices remain intact. We have to wear a mask, we have eye protection, other personal protective equipment. That doesn't change if you get the vaccine. So if you get the vaccine, you still have to go through all of this.
I think a number of households are going to be in a situation where one member has been vaccinated and is presumed immune and the other is not. To clarify, the person who's been immunized cannot give the vaccine, give the virus to their spouse or other person. But as you said, you can have it and bring it in. What about transmission on your body on bringing it in just physically? Is that a concern?
No, right. The greatest risk of transmitting the virus is through the air that you breathe out, right? Aerosols and small particle droplets. That's how the vast majority of viruses is transmitted that way. So you could be asymptomatic. In fact, even without the vaccine, you can have an asymptomatic infection and shed virus. So that's something to keep in mind when you get the vaccine.
Again, we talked about AstraZeneca. Do we know when that that vaccine may be available or other ones may be available, or are you not even really too concerned about it?
Well, it's slowly working its way through the FDA. I do not believe that they've applied for emergency use authorization yet. But as we saw with these other vaccines, the application for emergency use authorization and the eventual approval can happen quite quickly. So I wouldn't be surprised in the next several weeks or maybe a month or so, AstraZeneca vaccine is available. And I guess then the question becomes, well, we have these 2 really effective vaccines and these maybe a vaccine that's not quite as effective, but there's a shortage of vaccine. Should I get the AstraZeneca vaccine in lieu of waiting around for the other 2 vaccines? We have to sort of figure out where we are with all of that, but having a vaccine is better than having no vaccine. So we'll have to see what the situation looks like in a couple of months, if in fact the AstraZeneca vaccine gets approved.
I think this is going to reiterate something you said, but I want to be very clear. If someone has been immunized, had gotten the vaccine and is immunized, but let's say they're going to go visit somebody who's at risk, they still should get COVID tested, even if they are, and in fact they are immune, not even presumed immune. You still need to be COVID tested to make sure you're not, as you said, have it low level and bring it.
Right. So COVID testing is a bit of a wild card here, because if you've been immunized, you've gotten 2 doses, you're now 14 days after your 2nd dose, you're benefiting from the maximal protection of the vaccine, and you want to go visit somebody who's not been immunized, who may be at a high risk, it may be a high risk, wear a mask. For sure, wear a mask. Now, the testing issue, it depends on what type of test you get. If you get the rapid test, a negative test really has to be confirmed by what's called PCR test. So the bottom line here is that it's far more effective to just wear a mask than to go ahead and go through the testing routine. By all means, you can do that. And of course, the timing becomes an issue when you get the test and when you're seeing this other individual. But getting vaccinated should not change any of our practices, at least for the time being.
And to clarify, if I've been vaccinated and I'm presumed immune and I do get a COVID test, does that automatically mean the COVID test will be positive because I'm immune, or are they totally separate, my immunity versus the results of the test? They're separate. Very good.
Yeah,
just to clarify.
Separate, right. Yeah.
Okay. I warned everybody early that we're not going to be able to tell them when we can go back to a normal life. Some of the things I've read from Dr. Fauci and other people say anywhere from later this year to even next year. But what's the goal? I've read 90%, people getting it for herd immunity. So what is sort of the goal of the powers that be that are giving these out to achieve?
Right. I mean, obviously, we want to get as many people immunized as possible with effective vaccines. And when can we return to normal is really going to depend on probably 3 factors: the number of people who have been immunized, the number of people who have been infected, and how long the immunity lasts in individuals who have been either infected or got the vaccine? What's the durability of that immunity? And the third thing, of course, is how the virus is going to mutate. We have two examples right now of these two variants, and whether those mutations are going to make the virus less susceptible to the immunity that's provided by either infection or by the vaccine. So there's a lot of unanswered questions now. If all goes well and these variants are covered by the vaccine, the ideal circumstance, yeah, maybe later this year, maybe the fall, we're going to really go back to normal. But what we know about these viruses, they can be very unpredictable. So it's very, very difficult to say right now where we're going to be. And one other thing I should mention is, and this may come up as a question, what happens if you had COVID? Should you get the vaccine? And it certainly looks like the immunity that you develop from a COVID infection, typically we know that it seems to last for at least 90 days, maybe longer, and probably much longer in some individuals. So if you have a history of COVID and you want to get vaccinated, right now the recommendations are wait 90 days from the COVID infection and to being eligible for the vaccine.
And I just saw, literally a couple hours ago, I saw somebody from WHO who said, even if you've had it, you should get the Pfizer vaccine. I don't know if it was specific to Pfizer and they didn't give the dates, but there was another study or somebody else again came out today saying, even if you've had it, get the vaccine with the normal 2-dose. And we'll get more information about that, but that was reiterated at least by another committee today. Talk to us a little about, people are wondering, why aren't we just doing a mass vaccination? Why aren't we getting the National Guard out on field hospitals inoculating? Is it a limitation of the number of vaccines, or is it the government limiting that? Why can't we just blitz everybody?
Well, I think, we've never done this as a country. We've never had a mass vaccination program that needed to be done so quickly. And I think we're learning a lot of lessons here that we're just not equipped for it right now. And, that's been one of the issues. Of course, in Israel, everybody joined the army. Everybody's sort of used to routine. They're being a lot more efficient at getting vaccine out there. Getting the vaccine out there is really, really important based on the first couple of slides I showed, where this pandemic is really getting out of control. A difference of a week or two may make a huge difference in the disease that we're seeing. So, we all wish that this was done a lot more efficiently, but it doesn't seem to be that way.
Some people are wondering, if I just got COVID, just in the last few days, I'm positive, or let's say we've got some people in rehab or in the hospital that have been diagnosed with, do them getting the vaccine, does that help them at all? Are they getting the vaccine, or does that not matter once they've been diagnosed with, in terms of somehow helping their care or recuperation?
No, if somebody has COVID, getting the vaccine is really only going to protect them from later down the road potentially getting reinfected. As far as a therapeutic, it's not going to be very helpful.
Do you imagine we might get to a point where, if we do want to take a plane trip somewhere, we're going to have to show documentation that I have been immunized, or do you not see that being the case?
Right. Well, one can imagine that we're going to have a sort of a COVID passport, right? Or that may be required. It may not be required. I don't know. Different countries have different approaches to this, and I'm not so sure that's going to be the thing that we're going to do here in the United States. There may be institutions, hospitals that we work at, you work at, they're required to get flu vaccine. And I imagine that we're going to be required to get COVID vaccine. So it's going to depend on where you are. But as far as the airlines and transportation, so on, I don't know. But I think that the bottom line here is, get vaccinated, and we'll worry about that later.
Literally in the last 24 hours, there's been hot news topics, and then today there was an answer by the FDA about, should we give 1 dose only and spread it out so more people can get it? And I know there was a story yesterday. I heard an FDA response saying no today, but clarify that situation. Your data showed that 1 dose may be enough. So, what's the thinking, and what is the decision being made, and why?
Right. So there are two sort of storylines here. One is to give 1 dose instead of 2, and the other storyline is to get a half dose, maybe a half dose twice. The problem is that neither of those scenarios have been studied in large clinical trials. There's some data from earlier trials, the phase 2 trials of the Mrna Vaccine, where they were using different doses, but that was on a relatively small number of people. So we don't know whether whether this is a reasonable strategy or not. And I would be very surprised if we went to a program now where we're shifting to doing something that was not studied in the clinical trials. Now, I'll remind you that the 2 vaccines that we're using right now are under emergency use authorization by the FDA. And if we're going to change our strategy, then the FDA has to change their emergency use authorization. And they're not going to do that if there's no data. So although there's some excitement about this, I don't see this really happening unless there's a real shortage of vaccine. And now we have limited resources and we're going to have to deal with it. But more to come on that. I was surprised to see that. I just think it's an anticipation that we just may not have enough vaccine to go around.
And again, I did see a little blurb today, the FDA saying, no, we're not going to do that. Again, things, as you say, could change tomorrow. But they are at least answering these questions as fast as they can. I think I've covered, okay, we've got a few more questions. Some questions about the issues of storing. We hear that one of the vaccines has got to be kept at way below zero, another not so. And logistics aside, how does somebody know the place they're going is doing it the right way? Is it safer to get a vaccine to a hospital versus a clinic? Do we just intrinsically trust who's ever offering them that they're doing it appropriately?
Yes. Yeah, this has come up. There was, I guess, a pharmacist, I believe, in Wisconsin who intentionally tried to spoil some vaccine. There's this malfeasance out there. The Pfizer vaccine is the one that has to be kept at very cold temperatures. The Mrna vaccine actually doesn't require those cold temperatures and actually is quite stable at room temperature for a while. So again, get vaccinated. You'll have to have faith in the system that what they're putting into your arm is effective vaccine, and just you have to just trust the system.
By the same token, what are the concerns that people will get their first vaccine and for whatever reason they plan poorly, and when you're due for your second, it's not available? Has that become a problem? It's obviously early, but is there a concern of that? And what are the safeguards to make sure that those that got started will be continued?
Right. So there are a couple of issues here. One, of course, is that there won't be any vaccine available, and the other is just the scheduling issue here. The official recommendation from the CDC and the FDA for the Pfizer vaccine is you have a 4-day window. So it doesn't have to be exactly 21 days. It could be 2 days before, 2 days after. I believe the same is true for the Mrna vaccine, but in both cases, even if you're late to getting that second dose, go ahead and get that second dose. Even if it's a week later, even if it's a month later, go ahead and get that second dose.
Is it your expectation that when people, other than the healthcare professionals and the retirement communities that we're going, when people are starting to go out from the community, when they sign up and are approved to get a vaccine, they are guaranteed 2 doses? Because people are concerned, I'm going to sign up and I have no way to know if when I'm supposed to come back, they're going to have another. So is that the expectation that they're guaranteeing you that second one and saving it for you?
It all depends on where you're getting your vaccine. I think at the hospitals, they're obviously very concerned about this to make sure all the healthcare providers have gotten, have accessibility to the 2 doses. This is a big logistical issue here, making sure that there's enough vaccine to go around the second time around. But again, I think even if you're due for your vaccine, and it's not available 28 days for the Mrna vaccine, 21 days for the Pfizer vaccine after you gotten the first dose, then just make sure that get on those lists and make sure that you get your dose after the 21 or 28 days. So,
and as you said,
this is
certainly when you go,
logistical issues.
And as you said, when you go for the first one, certainly ask them. Say, will you have it? Will you have my name down? Will you have one reserved? And if you don't like the answer, I can't say try somewhere else, but at least you'll know what to expect.
Right.
I've got a few other questions here. I'm just looking at. Someone was told that they should not take Tylenol or Advil before getting the vaccine. Is that any information you're aware of?
No.
Okay, thank you. I'm checking. I think we've got most of the ones covered. Specifically, talk a little bit if you can. You know, my understanding is despite this whole vaccine and waiting our 21 days and then another 14 days, the bottom line is life is not going to change. As you said, we still need to wear our masks. We still need to social distance. Nothing is going to change drastically. Regarding things like synagogue, minyan, do you anticipate anything changing in the next few months? I mean, everybody's waiting for this vaccine, but the bottom line is, my understanding is life's not going to change for another, we don't know, 6 months, 8 months, significantly to the old way. So what are your expectations in the short term?
Right. The short term is, I think that the rest of this month and February and perhaps into March are going to be very dark months for this country. We have vaccine, but the rollout has been sluggish. The numbers continue to rise. I showed you on the first slide, a third of the new cases in the last 31 days. And there's no indication that this is going to stop anytime soon. We've seen a big peak after Memorial Day, 4th of July, of course, the Thanksgiving holidays. Now we're seeing the effects of the Christmas holiday and New Year's. We'll see that effect. In the next couple of months are going to be dark months for this country. And it's going to take a while before we have enough people immunized to really start halting the pandemic. So we have to get through these next few months and be extra careful in the things that we're doing. And even under those best of circumstances, the virus is going to find its way into communities. It's done that over and over again. So again, if you have an opportunity to get vaccinated, by all means get vaccinated. But and keep up with the mask wearing and the social distancing. Don't let your guard down. I know a lot of people are suffering from pandemic fatigue, COVID fatigue, and it's terrible. But this is not the time to let your guard down. Said that the way this virus is accelerating right now, it's going to find its way into every corner of this country. Even under ideal circumstances, getting the vaccine out to everybody, we're still not looking for a tremendous change in the arc of this pandemic for months. So we have to get through these next few months.
We've got to stay the course, right?
Yep.
Can you tell us, clarify, what should a woman who is or may soon be pregnant be thinking about the vaccine?
Right now, there's no contraindication to getting vaccinated. In the vaccine trials, of course, if you were pregnant, you were excluded. But with every vaccine trial, there are always women who sign up for the vaccine, and after they get their first dose, and perhaps even after they get their second dose, they realize that they were pregnant. And so there's always a small number of women who, unbeknownst to them or the study coordinators, got vaccine while they were pregnant. And although there are small numbers, there doesn't seem to be any adverse events of getting the vaccine.
You're a pediatrician. Tell us about kids. Should children be vaccinated?
So this is the big wild card when you think about immunizing a population. From the first couple of slides, you can see that the Pfizer vaccine is approved for individuals 16 years of age and older. Moderna, 18 years of age and older. So about 1/3 of our population is under 18 years of age. So we're going to have all these unimmunized kids running around. There are a number of clinical trials in progress right now looking at immunization of children. That's going to be a key component to really getting herd immunity. And I should have mentioned this earlier, but when you have a third of your population that is now susceptible to infection, it's unlikely that you're going to achieve herd immunity under those circumstances. So if you have a big pool of individuals who are still susceptible, it's very, very hard to put a cap on the pandemic. So hopefully those studies will be completed soon, and we'll start looking at immunizing younger children.
One person's asked, a little off the subject of the vaccine, but certainly related and something relevant for everybody. If someone thinks they were exposed, let's say yesterday, at what point should they be concerned of symptoms, and at what point should they feel comfortable saying, I guess I don't have it or didn't get it?
Right. So the average incubation period, in other words, the time between exposure and the first onset of symptoms, if you're going to have symptoms, is about 5.5 days. And we do know that for people who are exposed, 75% of those people are going to develop symptoms within the first 7 days of exposure. So if you make it to 7 days and you're not symptomatic, you may have escaped infection. There's still a 25% chance that you are infected and will become symptomatic. Of course, many people may get infected and not even know it. So this is one of the reasons why the CDC has added this wrinkle about quarantine, about getting tested to get released from quarantine. So that is an option. But again, we know the incubation period can be as long as 14 days. Most people are symptomatic by 5.5 days. By 7 days, 75% of the people who would start to show symptoms have started showing symptoms.
Thank you. A couple sort of deeper down questions. I don't know if you'll know the answers. Well, one is someone wants to know, is the FDA in any way related to either of the two or other major vaccine companies, or are they totally independent?
Totally independent. As a matter of fact, the FDA has a panel of independent experts who review these vaccines, and they're very, very strict about conflict of interests. So these are two independent bodies, and there's no potential conflict of interest.
Someone's asking, in terms of the fact that we can't get that many vaccines out there, is your understanding that it's a matter of production or distribution, or is it really both?
I think it's both. What we're seeing now is that there's a lot of vaccine that just hasn't been distributed and administered yet. So the first phase of this is really a distribution issue. But if you count up all the numbers of vaccines, there's clearly not enough to immunize the whole everybody who's eligible to be immunized. Now, of course, the vaccine companies are working very hard to provide other doses of vaccine, but until our distribution lines improve, we can have 328 million doses of vaccine for everybody, but if our distribution practices don't change, we're not going to get the vaccine out to people yet.
Jeff, I think that's all the questions we actually have. There's one other person who has a very complex and a personal specific allergy question. I'm going to ask them to get in touch with you, or vice versa. It's really not something for the whole group. Hold on, we have one more question that just came in, and we're doing okay on time, so I'm happy to look at the questions. Tell us, as you mentioned, you heard this somebody this malfeasance about throwing out some vaccines, but talk about the shelf life. I've heard in some places, if the vaccines are going to go, they're giving out to anybody they can, which seems prudent. But what can you tell us about the shelf life of these vaccines and the efficacy of getting these out there while these pharmacies, hospitals have them?
Right. So again, the Pfizer vaccine, the shelf life, at least at room temperature, is much less, or much shorter, I should say, than the shelf life of the Mrna vaccine. And again, I think that at least in the hospital setting, they're being very, very cautious with how they're handling these vaccines. And it ends up that they always get a little bit, the way that the pharmaceutical companies allocate these vaccines, they always have a little bit of they always put a little bit more in the vial than it's needed. And some people are actually squeezing another dose out of those vaccines, which is a good thing, I suppose. But you just have to have faith that the people, the individuals who are providing you the vaccine, are paying attention to all these aspects of the vaccine. So, this is no different from any other vaccine that we get. You just have to have that faith. And, the fact that you get two vaccines, that second booster dose, even if your response to the first vaccine may not be adequate, that booster dose could really improve your immunity quite dramatically. And that's true for other vaccines.
Someone's asking a question. I'm not quite sure I understand it, but just in case, are some of the vaccines different doses such that it may be a stronger Pfizer vaccine at one place than another? You're getting more or anything like that, and does that make a difference?
No, so all the Pfizer vaccine vials are all the same. The dose of the Pfizer vaccine is different from the Mrna vaccine because they're manufactured in different ways. So the dose that you get from the Pfizer vaccine is going to be different from the dose of the Mrna vaccine, but it's a standard dose. Again, I don't want to again address all this chatter about halving doses or whatever, but it should be that wherever you get your Pfizer vaccine, whether you get it here in North Texas or in New York or California or in England, the dose should be the same.
Someone has asked, what are the conditions that someone who is not 65, who's younger than 65, but will qualify for 1B, what are those conditions that make you eligible as a 1B if you're over 16 but under 65?
Right, and it's typically if you have underlying medical conditions. And again, these are listed here, and you know, it gets a little fuzzy here, right? Because if I'm over 65, I can walk over to Walgreens, show my driver's license, and they can figure out that I'm over 65. I'm not. But you know, whether you have emphysema or cardiac issue or immunosuppressed for some reason, obviously they can't figure that out by looking at a driver's license. And all the more reason that if you do have a chronic underlying medical condition and you're less than 65 years of age, contact your doctor, because they may be able to get you into a vaccine, get you in line for a vaccine. They have your medical records, they're affiliated with a hospital. Much easier to do it that way than to try to convince the pharmacist at Walgreens that yes, indeed, you do have two other medical conditions.
Someone's asked a very good question. Who's paying for all these vaccines that we're getting?
We all are. We all are. It's our tax money. That's who's paying for it.
But when you do go, it's free. You walk in and get a shot.
Apparently so. Yes. So that's who's paying. We're all paying for it. And as you notice, the death is getting bigger and bigger. But that's another story.
I don't think we have any other actual questions. I'd like you to make a few last points, but I know one of the things I tried to emphasize with you is nothing's going to change. Wear your masks, social distance like you've been doing. Don't change what you're doing just because you've been immunized.
That's it. I mean, as I said before, I'm afraid that we're in for some really dark. I mean, we've been through some dark months here. I mean, think about it. 1 in every 1,000 Americans has died due to COVID-19. We're seeing thousands of people die every day. Look what's going on in Los Angeles right now. In this country, we're actually triaging people because we have limited resources in certain hospitals. And the trends here in North Texas are very concerning. We may run out of ICU beds. And I know this has been a tremendous burden on all of us. Many of us know people who've been infected, who've been quite sick, taking care of very ill individuals, but this is not the time to let your guard down. In fact, we just have to push through the next couple of months, and I suspect by then maybe we'll start seeing the arc of this pandemic change. But by all means, be careful out there, wear your mask, wash your hands, wear eye protection or glasses if you're going to be in close quarters, and do these things. And and if you get an opportunity to get the vaccine, get the vaccine. I can't emphasize this enough. These are very safe vaccines. I got one. My arm was a little sore. I'll take that. And these reactions that we're hearing about are very, very rare. Now, of course, if you happen to have the reaction, it's not so rare. But you have to weigh the risk and benefit of the vaccine. And by all means, right now, it seems that the benefits far outweigh the risk. So, be diligent, keep checking on these websites, call your local pharmacy, call your physician's office, try to get your vaccine. And I certainly anticipate that more vaccine will become available and will be an opportunity to get our second dose. But be as diligent as you possibly can be. Don't let your guard down now.
I know Marcy just posted one of the websites, I think probably for the Texas State Department of Health, and I've got one for Dallas, but some people signed on early, some people left. So I'm going to ask Dan also to put that out somehow through the show if we can, so everyone can get it. But I know Marcy just posted one website. Websites are very valuable, though. The one I looked at just through Dallas Morning News said when 1B would be available, gave a list. So there are resources out there for everybody. And again, if you can't find them, call your doctor's office. They will help you. I think that's it. Any other last minute issues, if that's it?
Stay
Jeff,
safe.
thank you again. You are invaluable to our community, not just Anshai, but the broader community. And I have no doubt we'll have a third Dr. Kahn COVID talk, be it a month or 3 months again. But we look forward to that. Thank you very much.
Well,
thank you.
Thank you for the invitation. Thank you. Thank you all for the
Thank
invitation.
you.
Thank you.
Thank you, gentlemen.
Thank you,
Everybody
Jeffrey.
be safe.
Thank
Be
you
safe,
all.
everybody.
Thank you.
Thank you.
Thanks, Jeff and Mark.
Thank you.
Thank
Thank
you.
you all.
Thank you.
Thank you very
Thank you, everybody.
much, Doctors Kahn and Meiches.
Look at
Okay.
she's in bed, yeah.
Right?
Yeah.